Mrs. Erika Amon. Welcome, Erika, again. So, la señora Erika Amon es Area Manager Community Health de Healthcare New Zealand. La señora Erika Amon se licenció en farmacia y es máster en farmacia clínica. Ha desarrollado su carrera profesional durante 12 años en el ámbito de la atención primaria, antes de incorporarse a Healthcare New Zealand en el año 2010 como consultora del Servicio Nacional en el equipo también de atención integrada. Ha participado muy activamente en la implementación de una red de salud familiar integrada, T-Wiringa Ora, que me ha dicho que se llama TWO, que es mucho más fácil de pronunciar, en la bahía de Plenty, en el norte de Nueva Zelanda. Healthcare New Zealand es el mayor proveedor de servicios de salud de base comunitaria y el segundo proveedor de servicios residenciales en Nueva Zelanda. También es proveedor en menor medida de servicios de atención domiciliaria. Vamos a escuchar ahora a la señora Erika Amon. So welcome, Erika, again.
Gracias and buenos dias. Today I'm going to describe to you my experience in implementing an evidence-based integrated care service model and the ups and downs of this journey. I'll briefly cover a bit about health in New Zealand and the company I work for, but then describe the service model Te Whiringa Ora, or TWO, the results of the evaluation and what we believe the success factors were, and then what happened next, finishing with some lessons and my suggestions to you, because although you'll notice some similarities with earlier presentations, this one doesn't have such a happy ending. New Zealand has a population of about almost 4.8 million. Māori are the indigenous people of New Zealand and make up about 16% of the population. And like many indigenous groups, they make up a larger proportion of the lower socioeconomic population, and their health status is worse than non-Māori. As you can see, their life expectancy is 7 years less than European, which is better than it was a decade ago, but still not acceptable. And not surprisingly, you can see the mortality rates for chronic conditions are worse than non-Māori. The model of care I'm going to describe to you today is based in the Eastern Bay of Plenty of New Zealand. It's the North Island of New Zealand. This is an area where almost 50% of the population are Māori, compared to the 16% average throughout New Zealand. It is more rural, therefore has a declining population. 50% of the population are considered low socioeconomic, and 26% of Māori are unemployed. All are contributors to poor health status in this area. Very briefly, the organisation I work for, Healthcare of New Zealand, is a privately owned company, the largest provider of home-based and disability services in New Zealand. We provide services throughout New Zealand to those with disabilities, injury and age-related conditions to enable people to stay independent in their own homes. We have over 7,000 staff supporting over 18,000 clients, and this continues to grow. Te Whiringa Ora, in 2009, the then Health Minister requested proposals for new models of care that would address inequalities. Te Whiringa Ora was one of only 9 selected throughout New Zealand. Te Whiringa Ora is a Māori name, and it means to weave a web of care around a person. This model was implemented in partnership with the local primary health organisation, and funding was provided through this organisation. In designing this new model of care, our drivers were to make better use of the existing resources, so that is the providers that were in the local community, to make better use of the unregulated or non-clinically qualified staff. This enabled us to grow the workforce within the health system, knowing health professionals are a limited resource, and to make use of the greatest resource, the patients themselves. The idea was to make better use of the 5,000 hours. This concept is based on the fact that there are over 5,000 waking hours in a year. Yet even patients with chronic illness might spend only a few hours each year with a health professional, leaving over 5,000 hours where they're making decisions about their own health and well-being. Therefore, we wanted to influence and improve a client's self-management and self-efficacy, their belief in their own ability to complete tasks and reach goals. The objectives of the service were to focus on clients with chronic conditions who were often high users of hospital services, to provide case management and coordination, and assist them to make use of the various services available to them, to wrap a web of care around them, to help them navigate their way through the health and social systems, and all of this in order to reduce hospital admissions and emergency department attendance. The overall aim was to achieve this through improving a client's self-management and therefore be a sustainable change. So how does this service really work? Firstly, while building a relationship, the case manager, who is a registered nurse, would work with the client and family to complete an assessment. We use the Flinders assessment, which is a set of tools which measure the ability of clients with long-term conditions, their ability to self-manage their condition. From there, a patient-driven care plan would be developed, keeping in mind the mantra, what matters to you, rather than what is the matter with you, and therefore the patient-driven goals took priority. The plan coordinated actions and access to services over a support period of 3 to 6 months. The second part of the team, the health coach or navigator, would provide ongoing support, coaching them towards taking more responsibility to reach their goals. In some cases, we use telemonitors for short periods. Though designed for remote monitoring, we found they reinforced self-management by giving clients reassurance that they did understand their own signs and symptoms as they deteriorated and need to take action, or that certain interventions were having a positive effect on their condition. All of these interactions took place in their own home. So a diagrammatic representation would look like this. It shows that referrals can come from GP or family doctor, emergency department, hospital wards, or other community providers. Once they'd been assessed and patient goals are set for a period of case management. We also designed a web-based shared care patient record that could be viewed by the family and all providers involved in a client's care. But once the client's self-management improved and goals were met, they were discharged back to their lead provider, normally their family doctor. Our model corresponds nicely with the King's Fund model of integrated care, which we've modified slightly to describe the important components of our model. But the important parts are you need an activated and engaged client on the left. You have to have staff who coach and support but don't do for the client or create dependency. They're on the right. And it's important to point out that not all health professionals suit this model. And the most important component in the middle is the shared decision making, another area the King's Fund have written extensively about. All of these together will lead to optimal outcomes, in particular the triple aim outcomes. And if you meet these outcomes, it will continue to reinforce and encourage the activated patient. So some examples of those goals. You'll note these aren't the traditional goals that we'd normally see, so to be able to ride my bicycle again, with traditional health goals sort of sitting in underneath. Another example, to travel to Australia to visit family. The service started early in 2011, and in 2013 we took the first 250 clients who went through the program and evaluated a range of outcomes, including their utilisation of hospital services for the year before they entered the service and the year after. Now, half this group were Māori and over half were women, average age of 69, and an average length of stay in the service of 5 months. We used the triple aim framework to measure and consider the outcomes. The first dimension is around the patient experience, and client interviews suggested that TWO was appropriate for Māori, for non-Māori, and those that would disengage with health services. It was responsive to a client's needs and readiness to engage, and importantly, it had a holistic approach. It looked at what in a person's life needed addressing to enable them to manage their health. General practice teams were also complementary, stating that TWO team would chase and follow up with those that didn't attend appointments and took some of the load off their general practice teams, sorting through some of the client issues. Second dimension of triple aim focuses on improving population health outcomes. And this evaluation compared the changes in the utilisation before and after the entry into the service for the enrolled group. We used a comparison group, people that were not enrolled in TWO but met the criteria who received the usual care. Obviously, it assumed the members of the enrolled group would have followed the same disease progression and changes in hospital service utilisation as the comparison group in the absence of the TWO service. Above is a subset of the results, but overall the analysis identified a reduction in bed days for TWO clients when compared to their historical trend. This is an important finding given the degenerative conditions they have and demonstrated the important role TW had in reducing preventable hospital admissions and avoiding any length of stay. The emergency department presentations were occurring less frequently for most, also suggesting clients were experiencing better management of their conditions. Using the SF12 tool, we were able to measure the quality of life before and after, and this too showed that both physical and mental health scores showed a statistically significant improvement for TWO clients. Also an important and unexpected finding given the clients had multiple long-term conditions. The third dimension of triple aim. This shows a diagrammatic way that the utilisation of hospital services reduced for the enrolled group, which are in blue, as they entered TWO, and the comparison group is in red, suggesting their conditions deteriorated over time. You'll notice the split there of COPD patients because that was the first cohort of clients that we enrolled as we started the service. The third dimension of triple aim is to reduce the cost of health being delivered to these clients. Now, this was a fairly intensive service up front, and therefore some considered this expensive, and the question was, would it save money in the long run? So we commissioned a cost minimisation study using that previous data, and this graph shows the change in costs for the enrolled and the comparison groups, and not surprising, the most material reduction in hospital costs was related to the inpatient services. TWO was associated with an average annual savings of about €2,200 per person post-enrolment, and extrapolated over 5 years with a conservative attrition rate, we could see savings exceeded the delivery costs, and at full capacity, break-even was expected at 1 year. So what enabled this self-management? There's a significant paradigm shift, we believe, in the way we were delivering the service. As Eric talked about before, the patient was in the driver's seat. They were patient goals, not medical goals. We looked for quick wins to get patients engaged again, as many had had bad experiences in the health system in the past. This was all focused on self-management, not a dependency model. The service model allowed more time with the patient in order to increase that level of client engagement, which of course is a luxury in the health system. We took a holistic view, focusing on the barriers that might inhibit a focus on their health. This might mean assisting with getting benefits or helping getting funding to have a house insulated. The health coach support was crucial. We found that the non-clinical staff often managed the case coordination better or were more acceptable to the patient than the health professional. In the setting, services were delivered in the home, where the patient was more comfortable, and it gave us a greater view into the issues the patient was facing. And as I said earlier, telehealth reinforced some of those lessons for some. So some of the lessons that we learnt in this part of the service. There's a huge investment up front in developing and debating every component of that service model, ensuring it was aligned with the concept of integrated care and self-management. You have to be patient because it takes time for the team to evolve. Good training and leadership for the unregulated workforce was required, and uptake to full capacity, the number of referrals coming in, takes time, so you'll not be as efficient or cost-effective in the first couple of years. The assessment tool must match the philosophy of the service. We got that wrong initially using an assessment tool that was being introduced nationally, but it didn't match the self-management philosophy. You must design the evaluation framework at the beginning and do regular service reviews. And you need to consider what barriers you might need to overcome to implement a new service. In our case, there'd been a shifting of funding, which caused quite a barrier for us. So it was all looking great. We had things to work on. What could go wrong? So not long after that positive evaluation, the funder proposed the service redesign. They wanted greater control, reduced cost, and greater integration with general practice. The contract as it was to be terminated in March 2014. It was then extended another 3 months as they actually hadn't completed or worked out their service redesign. But the new contract and modified service began in July 2014. 2 years later, in May 2016, we received notification from the funder that they would bring the service in-house by the end of the year. And in December, just before Christmas, our staff moved across to the primary health organisation to continue the service. During that period of change, there were a number of things that we noticed. The PHO reduced the funding and took over the administration and to some extent the management of the service. Referrals had to come through the general practitioner, so they became a gatekeeper. So there was no capture of clients or patients through the emergency department, through hospital wards, community providers, so we missed the disengaged, those who weren't seeing the GP. In New Zealand, you have to pay to see a GP, so that can be a barrier for some. The care plan had to be started by the GP, so the GP goals took priority over the patients. They became the focus. Although, to be fair, our staff were still the same, so they did try very hard to focus on the patient's goals. Our company, Healthcare New Zealand, lost the ability to collect and monitor the results, so there was no evaluation and the focus on outcomes was lost. The service had ceased for 3 months while they were designing or redesigning that service, so that didn't help the continuity of referrals or the reputation of the service. Referrals dropped to a lower level than they had been before, and this was also partially due to all clients having to be identified and referred by the GP. The type of client changed. They became younger. Many were looking for a quick fix. Many were self-managing quite well, but may have had an acute event. There was more focus on the preventative care, which is not necessarily a bad thing, but less of those that were disengaged and not managing were entering the service. There were also more declines, as often the clients didn't know they'd been referred or had given consent, so certainly not activated. And the focus on self-management was lost slightly. There was less rigour in the model due to a drop in nursing hours and management and a loss of oversight of the program. For instance, the assessment tool stopped being used, and there was obviously no monitoring or evaluation. So, my suggestions to you, and if you find yourself in the position of designing or implementing or funding a model of care, stay true to the philosophy of integrated care. The World Health Organization Global Strategy reminds us to empower and engage people to ensure that we're reaching the underserved and marginalised. It's about the patient, not the organisation. Use the evidence to develop your model, don't disregard it. There's still a lot of good going on in this service due to the staff being the same, but I don't believe it's as effective as it was. And be brave enough to evaluate what you do, rather than be arrogant enough to assume that you don't need to. Because at the end of the day, this is what should drive us. Thank you.
Thanks a lot, Erika. So, muchas gracias, Erika Amon, por esta interesante presentación de un modelo que entendemos que fue pionero en Nueva Zelanda, buscando con el Te Wiringa ahora una nueva manera de cuidar a las personas más necesitadas, pero que al final hemos visto en la parte final de presentación que a veces, a pesar de ser modelos exitosos, los modelos de financiación, los modelos de decisión de los países a veces no confían en quizá modelos que son demasiado innovadores o demasiado creativos, y tenemos que seguir insistiendo y persistiendo en buscar estas nuevas maneras de tener un modelo integrado de salud para nuestras personas. Este modelo se ha basado en utilizar los recursos existentes, basado mucho en el modelo de autocuidado de las personas, y con una metodología muy clara en la cual se identificaban a las personas necesitadas, se buscaba un modelo de actuación y estabilización rápida para después delegar la responsabilidad en la salud, en el cuidado, en las personas, con un modelo integral de autocuidado y con esta red de cuidado alrededor de estos pacientes más necesitados. Al final hemos visto que poniendo pequeños objetivos, como ir de nuevo en bicicleta, las personas también eran capaces de alcanzar unos retos que al principio los veían como inalcanzables. Y todo esto intentando mejorar la experiencia del paciente con indicadores claros, con un objetivo a resultados e intentando siempre tener un modelo eficiente, un modelo de reducción de costes que nos asegure la sostenibilidad, pero siempre con esta atención de salud integrada y centrada en las personas. Thanks a lot once again, Erika.